Hi friends and followers, welcome to the Thorax Center's view on the large cardiology meetings for Radcliffe Cardiology. My name is Nicolas van Mieghem and I'm standing here in San Francisco to cover the TCT 2019 meeting together with my friend and colleague Joost Dame. We start with the most interesting antiplatelet drug trials, so Joost, take it away.
So the late breaker started on Thursday, September 26th with Twilight. So this study, which finally randomized 7,000 high bleeding risk patients with an operator-defined indication for ticagrelor plus post-PCI, to either ticagrelor alone or a combination of ticagrelor plus aspirin if event-free at 3 months post-PCI. So the trial was powered for a clinically relevant bleeding endpoint, being either BARC 2, 3 or 5, and assumed a 28% reduction in this primary endpoint at 1 year. So in our preview, I questioned the likelihood of this trial would become positive, but the trial actually appeared to be designed very smart, including a close oversight, event adjudication by an independent critical event committee, and there was an enrollment of a considerable amount of patients from Asia and India who simply tend to have a higher risk of bleeding anyhow. So the study then also met its primary endpoint and showed a significant absolute risk reduction of 3% when aspirin was stopped early, while the risk for ischemic events was actually exactly identical. So of interest to me were the absolute event rates and in particular the bleeding rates. So that proved to be almost twice as high as in a post hoc analysis of the Global Leaders trial, which was presented 1 day later by Yoshinobu Onuma, which again, at least in my opinion, reflects the impact of ethnicity and patient background, and also the way of oversight in the study, along with a CAC that clearly impacted the observed event rates. So overall, very interesting findings that are of great importance and apply to over 40% of the patients that we encounter in routine practice.
But in my opinion, in light of the Twilight, it was quite striking that 35% of the patients were either asymptomatic or had stable coronary artery disease, so off-label indications for ticagrelor. So truly a remarkable trial.
Yeah, no, I agree. So later on Thursday, 2 more studies on DAPT duration related to specific DES platforms were presented. First, Stefan Windecker presented the findings of the Onyx 1 study, designed to evaluate the clinical safety and effectiveness of the Resolute Onyx stent in subjects deemed at high bleeding risk to receive 1 month of DAPT. So the trial eventually randomized 2,000 patients to either the Resolute Onyx stent or the polymer-free BioFreedom stent, which already proved to be safe with short DAPT, and had a composite endpoint of cardiac death, MR, stent thrombosis at 1 year follow-up. So the trial indeed actually met its primary endpoint with completely overlapping event curves at 1 year, and confirmed thereby the safety of a 1 month DAPT strategy in patients treated with the biodegradable polymer DES. So 2 more studies on the topic. AJ Courtney presented the primary results of the single-arm EVOLVE short DAPT study, which assessed the safety and efficacy of a 3-month DAPT regimen in over 2,000 high bleeding risk patients treated with the bioresorbable polymer Synergy stent who were taken off DAPT after 3 months free of ischemic events, so as like in Twilight. So as compared to a historical control group, a shorter DAPT duration proved to be non-inferior and thereby suggests that a 3-month DAPT regimen might be feasible in patients treated with the Synergy stent as well. So following the EVOLVE short DAPT study, the Model U CES study was presented by Ken Kozuma, which actually showed similar findings when this strategy was applied to patients in which the biodegradable polymer sirolimus-eluting Ultimaster stent was used with a 3-month DAPT regimen, which eventually appeared just as safe and potentially slightly safer in terms of BARC 3 and 5 bleeding as compared to a historical control group.
So my question is, why would we only use short DAPT regimens in patients at a high bleeding risk? I mean, the ischemic outcome appears similar. So I think the last word hasn't been said on this topic anyway.
Yeah, no, that's definitely correct. So finally, on Thursday, Robert-Jan van Guns presented the IDEAL-F main study, which randomized over 800 patients to either a Synergy biodegradable polymer stent with 4 months of DAPT as compared to a control group of patients treated with a Zyne stent and 12 months of DAPT for a primary endpoint of death, MI and TVR at 2 years. So although the trial indeed met its primary non-inferiority endpoint, suggesting potential safety of stopping DAPT early in these high-risk patients, there was some discussion on the study because of the wide non-inferiority margin, which was actually 7.5%, and the absolute difference in the event rates, which appeared to be 3.2% in favor of the Zines group with the longer DAPT strategy. While unexpectedly, bleeding bar 3 or 5 was actually significantly higher in the short DAPT cohort, something which was also a bit counterintuitive. So in summary, an interesting study, but in contrast to the studies presented earlier that day, I'm not sure what the implications of this study will be on our practice, honestly.
Well, I'd say ideal left main was somewhat disappointing because the trial did not bring any new insights to the table. And I also had the impression that questions were raised about the design and conclusion. So,
that's true.
Yeah.
That's true. So, Nicholas, what were the highlights in the structural space?
Well, obviously, Scope 1. That was a TAVR trial comparing the Accurate valve by Boston Scientific versus the SAPIEN 3 in 730 intermediate risk patients for an early composite safety and efficacy endpoint at 30 days, including acute kidney injury and paravalvular leaks. The mean age of the patients was 82, mean STS less than 4. Remarkably, SAPIEN 3 proved to be superior to Accurate for the primary endpoint with a 7% absolute reduction. So Accurate did not reach non-inferiority relative to SAPIEN 3. That was quite striking, and predominantly the results were driven by more than mild PVL with Accurate, 3 times as expected, so lower than with Accurate. What was particularly concerning for Accurate was the longer procedure time, more contrast, and more need for a second valve. 3% of the patients required a second valve versus only 1% with SAPIEN 3. So, and the pacemaker rate was similar, around 10%. So, why was this so? Why was it so different, Accurate versus SAPIEN 3? I don't know, because Accurate in our center is quite a straightforward procedure with an easy top-down deployment. I assume that the next generation Accurate with a sealing fabric might help improve PVL outcome down the stretch, and hopefully then for Accurate at least make it the difference less with SAPIEN 3. Portico, on the other hand, established the non-inferiority of the Portico valve versus commercially available valves in the United States in 750 high-risk patients, age 83, mean STS 6.5%, with a safety endpoint at 30 days and efficacy endpoint in terms of mortality and stroke at 1 year. In the control arm, 35% received a valve from the CoreValve family. The majority, however, got a SAPIEN 3 valve. Eventually, Portico ended to be non-inferior in terms of the primary safety endpoint at 30 days, which was the composite of all kinds of events. There was a 4% absolute difference and higher with Portico, but with a predefined non-inferiority margin of 8.5%. So
very wide.
Yes, but the conclusion was that Portico was non-inferior to the established valves. Also, the efficacy endpoint, a composite of death or disabling stroke, was non-inferior at 1 year. There was an increase in more than mild PVL with Portico, as expected, and all the endpoints tended to be numerically at least higher with Portico. So conversely, gradients seem better with Portico. I think the next generation Portico Flex might provide some improvements. It introduces a lower device profile and an improved delivery system, and that was introduced in a registry of 100 patients and eventually ended up with less major vascular complications. I think another device iteration is underway to reduce paravalvular leaks, and that is under testing. Next up was the Partner 3 CT, MSCT sub-study presented by Raj Makkar. Serial CTs were available in up to 372 patients, SAVR or TAVR. And at 30 days, HALT, so leaflet thickening, was present in 13% of the TAVR patients versus 5% of the SAVR patients. And at 1 year, this compared with 27% with TAVR and 20% with SAVR. So what to make of that? Importantly, HALT was a dynamic process and seemed to resolve without oral anticoagulant therapy in 50% of the patients. Also, in 20% of the cases at 1 year, there was no HALT at 30 days. So a very dynamic process, and I don't think that we already have a full feel of it, of what's happening there. The clinical impact of HALT remains unclear. Although although gradients might be marginally higher, there was no significant increase in events in the HALT. or stroke, no. So the overall consensus of the investigators and the panel was that these findings were quite reassuring, let alone that they would require oral or justify oral anticoagulant therapy. The last trial on structural heart interventions was the 3-year follow-up of COAPS. Michael Mack presented the data. Remarkably, 38% of the control arm who did not receive a MitraClip out to 2 years crossed over and got a MitraClip. So that is significant. The cumulative hospitalizations remained clearly lower in the original MitraClip arm. Although it is sobering that even in the MitraClip arm, a heart failure hospitalization at 3 years was still almost 50%.
Yeah.
So 50% of the patients required a re-hospitalization. But in the control arm, it was a staggering 80%.
Wow.
Yeah, so that is quite impressive. The MitraClip reduced mortality at 3 years from 55 to 43%. And importantly, patients who crossed over after 2 years, who received the MitraClip, did markedly better than the patients who remained without a MitraClip. So I think MitraClip definitely has an established role now in heart failure patients with functional mitral regurgitation. Yeah. So let's go back to the coronaries. We wanted to learn more from David Wood from the COMPLETE trial.
Yes, definitely. So on Saturday, the COMPLETE timing sub-study was presented. Just to remind you, COMPLETE was showed that in 2,000 STEMI patients with multivessel disease, complete revascularization resulted in a significant 26% reduction in heart clinical endpoints, being death and MI, as compared to culprit-only treatment at 3 years. So here at TCT, David Wood presented the pre-specified timing sub-study, in which the investigators actually concluded that irrespective of the timing of the complete revascularization, so either during the index hospitalization or following discharge, was superior to culprit-only strategy. One other interesting finding in this study was the fact that the benefit of complete revascularization on heart clinical endpoints mainly emerged over the longer term, so up to even show data up to 5 years. Finally, as we knew from the design of the study, no word on the potential benefit of ad hoc versus staged revasc in general, a question that will be addressed in the ongoing BioVasc trial, which is currently randomizing ACS patients to either staged or direct complete revasc.
I couldn't agree more. I think BioVasc really becomes a much needed complementary addition to the COMPLETE trial.
Yeah, for sure. So on Saturday, something completely different. Karl-Heinz Kook presented the Moderato II study, which, as mentioned in our preview, was to me of interest since this is again an alternative device-based therapy designed to improve blood pressure control in hypertensive patients decently tested in a randomized controlled trial setting. So in this case, no real innovation, but a pacemaker-based programmable hypertension device that used a sequence of variable timing in the AV interval to modulate blood pressure. So the concept of the system is based on the fact that in patients with normal sinus rhythm, variations in AV delay are known to modulate LV filling and thereby, as a consequence, impact blood pressure. So we anticipated a true randomized study, including 170 patients. However, the trial indeed did screen 170 patients. However, finally, only 68 patients received the Moderato implant, and moreover, the final therapy was only initiated in 46 patients, meeting the blood pressure criteria after 1 month. So despite the small sample size of the study, it showed quite promising findings with a significant drop in 24-hour ABPM at 6 months of 8 millimeters of mercury, which was greater than the control group. Of further interest, the effect was observed virtually immediately after the device was activated and actually remained more or less stable at 3 and 6 months.
Not sure whether this will become clinically relevant. But
we'll have to see. We'll have to see. A larger study is planned, actually. So finally, on the last day of TCT, Francesco Borzotta presented the final results of the Forza trial, which is a study that randomized 350 patients with mainly stable angina and intermediate coronary artery stenosis to either FFI-guided treatment strategy or OCT-guided treatment, and was powered for a reduction in the primary endpoint of MACE plus angina at 13 months, assuming that OCT-guided treatment would reduce event rates by 50%. So against our expectations, please remember last year we already learned that a higher percentage of patients with FFR-guided treatment were deferred as compared to those with OCT, 70 versus 40%. However, the trial showed that at 13 months, the primary endpoint of MACE and angina occurred in 15% of the patients with the FFR treatment versus 8% in those with OCT-guided treatment. So quite striking. Furthermore, OCT-guided treatment appeared to be associated with significantly higher cost, as expected, as compared to a FFR-guided treatment strategy. So I'm still puzzled. I mean, there are a lot of things in the study I cannot get a hold on, and I look forward to reading the details in the study that will be published in JACC Cardiovascular Intervention very soon.
Yeah, so I will repeat myself from our preview, but I wonder whether we should treat all lesions equally. I think some lesions just need more OCT than others to obtain the best long-term results. And as far as the cost issue is concerned, we will need to figure that one out as a cardiology community. So with that, I would like to wrap up this TCT 2019. Thank you, Joost, and also thank you for your continued interest in our coverage of the major cardiology meetings.
Thanks for watching. Bye-bye.